Thank you, Adi, and good morning. My topic essentially is going to be comparing autogenous bone in BMP2. I did a webinar on this particular topic. This is kind of an extraction of that and a distillation of it to a degree, and a few new things. I do have some academic affiliations which I think are very appropriate in this day and age to be able to keep current, and I very much appreciate these with the residents and grad students at these respective institutions. I also have my institute that's been going on now for some 22 years. I've enjoyed being part of an education process because part of me as an educator really does enjoy that element as much as my clinical practice, which I'm still active, by the way, 4 days a week, entering my 30th year here in just a few months. So I've enjoyed the best of both worlds, so to speak, and as a result have had the advantage of being able to interface with a number of individuals like yourselves from all over the world now, all 50 states and a number of countries. But most importantly to me is what you see at the very top, and that is 3D diagnosis and treatment planning. And Marcus Abboud really put things in perspective quite well yesterday, because this is at the heart of what I feel this is all about for all of us. 8.5 years ago, I underwent pretty much a paradigm shift with regard to the impact of cone beam CT and how to practice. And it's impacted how I practice and certainly what goes on in our institute. In this day and age of high technology, I should say, images can be easily changed. I mean, we can grow bone, grow soft tissue at the push of a button, and I think it's always important to have this disclaimer for any particular talk. In the time frame I have with you, I would like to share just briefly some science of comparing autogenous bone and BMP2. Get it quickly an overview of our sequential digital diagnostic protocol, and then present some clinical cases and summarize have some summary comments with regard to comparing these two protocols. Most importantly, when we look at tissue engineering, and there's so much to this topic, by the way, this really is doing a disservice to this phenomenal technology that we now can embrace, but tissue engineering is here to stay, and without question, there are some basic principles we have to look at, and looking at cells and the signal and matrix concept, this tissue engineering triangle, as it's been called, and Bob Marks really has talked about this for quite some time. It's important that we appreciate the fact that the cells we're talking about in all the tissue engineering concepts are stem cells. And it's the cellular component along with the signal that makes things happen so well. And in fact, the differentiating factors, these particular cytokines as they're called, are numerous. And as you see here, some of them are listed. But the signal along with the cell, and most impressively, as we're going to see, the matrix is what makes things happen. But most impressively, with regard to the growth factors, they're pleiotropic. That's a Greek term for things happening a lot at the same time. And as we're going to see, angiogenesis, of course, is huge. Mitogenesis is another one. The mitogens that we have available to us, PRF, PRGF, PRP. And you're going to hear, you already heard on PRGF yesterday by Dr. Anitua, and then later today you'll hear from Dr. Shukran with regard to PRF. But these are mitogens. These literally increase numbers of cells, period. And that's a great thing. But from a differentiation perspective, we have only one mitogen morphogen, and that's BMP2 that's FDA approved for use, at least today in our country. And the upregulation of normal cell functions, of course, is huge. Now the matrix, which completes the triangle, is composed of these different scaffolds, and the biologic ones are, as you see here, fibrin, fibronectin from plasma, and vitronectin from platelets. We can add artificial scaffolds, as we're going to see, and that's really what makes things happen with regard to completing this triangle and making things better. If we compare, though, to autogenous bone grafting, which is considered the quote-unquote gold standard, well, then there's no question that there's a reason for it to be called the gold standard. And I know a number of us that continue to work with autogenous bone to a decent degree are all in pretty much are on the same page with regard to the value of autogenous bone. Because for sure, the cells, the matrix, and the signals are all built into this particular arena of protocols that we play with. So in essence, autogenous bone contains all three of these particular elements and items that are needed for bone to grow. And it's even possible to enhance one or more of the components of the triangle, as we'll see here. In fact, there's 4 ways. We can up-regulate the signal itself by adding growth factors. So we'll add PRGF, PRF, PRP, take your pick, even recombinant PDGF as mitogens only to our graft complexes. And if nothing else, they will upregulate at least VEGF that we know of for sure, which means it accelerates soft tissue healing, and that's a great thing. In addition, of course, we can handle our graft better by using these particular protocols and mitogens. We also can upregulate the matrix by adding, a number of allograft materials, xenografts, etc. So take your pick, and there's methods to the madness. Time doesn't permit to get into any detail. In fact, this topic is actually a day and a half of material condensed into 30 minutes. But we can increase the cell component by increasing the number of stem cells per unit in the graft by just condensing the source of stem cells in our graft complex, or we can increase the number of stem cells, period. So we have different ways to enhance this entire process. Now, if we look at BMP by itself, believe it or not, it's made in a hamster ovary. That's really the origin of it, this recombinant protein. And by a series of processes, it's freeze-dried or lyophilized, if you will. It's reconstituted with sterile water. The concentration is the same. It's a 1.5 milligram concentration. Unfortunately, the matrix, which is a collagen sponge, is really insufficient to maintain space. And as you see on the far right, it's 90% air, really. As we reconstitute it with the powder liquid, letting it sit for 15 minutes, that activates the protein and in essence makes it very perfect for our use, as you're going to see. Comes in different sizes from anywhere from about $900 to $6,000. So got to be pretty selective and careful when you use it. There are indications like anything else, as we're going to see, compare and contrast. I won't get into too much detail here except to tell you that the science behind this is absolutely off the charts with randomized controlled studies, no question. Unfortunately, for sinus grafting and for extraction site application, it's FDA approved. Everything else is considered off-label, and for the most part, all of my application is off-label. And that's just how it is. Doesn't mean it's illegal, just means it's not FDA approved. And the mechanism of action, again, I'm not going to get into a lot of detail except to tell you that de novo bone formation is the bottom line. This is the only technology we have that creates bone by itself. We can place this protein in your belly, in your bicep, in your butt, and it will make bone. And that's a good thing. That's a very good thing. And in my 5-year clinical experience, which was 5 years as of December, really includes more than 160 cases now for this application. And essentially what you're seeing here is, for the most part, all off-label. And but I will tell you that, it's a discussion in itself, that there are so many great uses for this particular technology. But like anything else, if we don't understand the biology and the application of it, we can get burned. Nothing's 100%. I've summarized a lot of this material in an article that I had published here last year that you're able to look at your convenience. With regard to all of the grafting procedures that I do, in fact, all of my patients, literally every one of my patients for the past 8.5 years gets a CT scan right from the get-go. And I think it's real important that we do a sequential digital diagnostic workup on all of our patients. And I can tell you, radiation aside, that it's not such a big ordeal to scan them up front and to scan them later. We'll post-graft scan, as I'll talk about again in our session this afternoon. And the value of that is huge. But to me, this is like the new Dawson mirror that everybody can remember, engaging with the patient. We have a big flat panel in every room. And I engage the patient immediately by saying, "Mrs. Jones," and they can appreciate a panoramic view. "This is you. I'm looking right at you from right to left. If we slice anywhere here, it's like having an apple in my hand. I slice it in half, I turn it 90 degrees, and I'm looking at the core." They understand that. And then I look up at the screen and I say, "This is your core, right here. Your bone is too skinny. We need to make it fatter, or we need to make it higher." I don't even use the words bone graft. So they get it. They understand the why of what we're up to, all because of this technology. So, most importantly, and I can do that, of course, in no time. And I can also quickly assess any potential donor sites if we're going to take bone from the ramus or from the chin or any part of the skeletal complex for that matter. But most impressively, we reduce surgical risk and complications with this technology. It's huge. It is absolutely huge. Now, in terms of comparing the two protocols, I'm just going to tell you briefly, anatomy is going to play a huge role with regard to what we're doing. The recipient site itself, how bad is the defect, what's the nature of it, will impact which way to go. The donor site, sometimes we don't have adequate bone in the ramus or the chin, for that matter, if we're going to take any types of block bone, for example, etc. Some patients don't have adequate bone to do that, do not. So that's going to drive things. The age of the patient is a factor. Medical history, some of our patients are so compromised, it's not really such a great idea to use any part of their mandible, for example, if we're going to harvest bone there. And certainly clinical and patient preference, but most importantly, skill sets of the clinician. And what I've found over the years, and I know Craig Mish and a number of us that we're on the same page with these types of autogenous bone grafting procedures, that if the skill sets aren't there, the clinician's just not going to go there. And that makes sense. So either understand and learn the protocol and use it as part of your armamentarium, or then perhaps you need to look at a different type of protocol, and that's okay too. This is Catherine. Catherine was 18 years old at the time, congenitally missing laterals as we see here. Nice high smile line, thin gingival biotype. Not such a great start right off the bat. A very challenge for any of us, certainly, to replace these teeth. The only way we can assess what's going on in terms of existing bone is with what? A sagittal CBCT section. That's it. Bone sounding PAs like we used to do, that only got us so far. Then we played off of what we found intraoperatively. This is a game changer, this technology. It's a game changer. So we can assess what's going on in her case, a width deficiency, and it turns out to be a width deficiency only on the facial element. So that's interesting, and that's fine. And there's different ways we can handle this type of a defect. We certainly can use a GBR technique, but for a number of these adolescent patients, it takes literally 10 minutes to harvest a ramus buccal shelf block graft. We can section it in two pieces, fixate it just as you see here, and we can then graft, or overgraft, I should say, as you're going to see, with a particulate PRGF complex. But the bottom line is these grafts do work. There's no question about the if. And yes, they take some time to turn over, but I will tell you in a matter of in 4 months, we'll re-enter this site and have D2 quality bone, even D1 bone, because the bone density is taken to that site by or from the donor bone itself. In other words, we're transplanting from here to here. There's no question, is it a mineralized matrix? Is it bone? It is bone. We know that. There's no question. And having done these now for more than 20 years, there's absolutely no question, having taught it for that many years. We overgraft with a particulate mineralized allograft, in this case Mineros. We use PRGF as a great bioactive modifier I've used for some 8+ years. Prior to that, 10, 11 years was PRP. These, again, modifiers allow you to handle the graft particulate more easily. We'll place a membrane over everything, and even using a fibrin clot from this particular technology, which really enhances and upregulates growth factors beautifully. So the long and short of it is we have a combination of tissue engineering and autogenous bone grafting combined. And the value of a post-graft scan, whether we're sinus grafting, whether we're socket grafting, whether we're ridge splitting, whether we're particulate mesh grafting, whatever the case may be, no guesswork. Who wants to be surprised when you re-enter? Not me. So we can post-graft scan and know exactly, did we hit the bullseye? Is the bone good? Is the density adequate? Did we have any resorption? And if so, was it too much to preclude implant placement? And here you see with these great volumetric renderings using Simplant, we can now virtually place our implant abutment crown complex within the confines of the new grafted outline and volume, and making sure that we're going to be able to utilize an intraoperative guide that will perfectly position our implants. We premucosally remove screws. That's been going on for 8-9 years. We don't have to flap these and talk about minimally invasive approaches, absolutely. And that way we minimize our flap elevation to what? Just crestal. Why crestal only? Well, heck, we can contour our bone like you see here and put the implant body in 3 dimensions exactly where it needs to be. And as Dennis and Stephen so nicely have shown, and we've known a number of these types of protocols over the years in terms of exact implant placement three-dimensionally. You can only do that with some flapping and contouring. If we did this completely flapless, I'm not sure how you can obtain that kind of a result. But most importantly, 3D, we know where things are at. Now, if I showed you this image and said, hey, what do you think? Maybe not such a bad result. Well, those papillae don't look so great. I think you would agree. On either side of the lateral, both sides, right and left. However, if I told you this was about 4 or 5 weeks post-prosthetic completion, then you'd say, okay, well, maybe, Mike, you're onto something here. Well, of course we know with time, and in some cases 6, 8 months it may take, but if we have that point contact to crest of bone, as Dennis has shown from way back, we know we're going to get a great result with a single tooth implant next to a tooth. We know that. That's a no-brainer, no question. And we also know from our colleagues, our Team Atlanta colleagues, the interproximal height of bone is huge in terms of its value, and this being class 1, we also know that this adds to the predictability of what's going to happen. So it is a no-brainer, even in a thin gingival biotype. So we took this patient and used an autogenous bone and got a not-so-bad result. I think you'll agree. She's 3.5 years, well, 3+ years out now. She's really 4+ total. This is Victoria. Now, Victoria is 17 at the time, and she comes to us also congenital missing lateral incisor, 1 tooth only, just the maxillary right side, as you see here. And if we looked at her clinically, we would maybe start to assume that, you've seen one, maybe you've seen them all. A lot of these folks are horizontally deficient, sure. But if we really zero in on this, and I do have the CareStream 9300, all 3 of our offices, we've had it now for some 1.5 years, almost 2 years. We replaced the 9500 with this. It's a beautiful system, beautiful unit to play with. Here, look at that. Anybody care to ridge split that? I mean, really, how thin is that? Well, the reality is Victoria's got an issue not only on the facial, but where else? On the pellet. Now, what can we do here? Anybody want to block graft this case? You could. Facially, pelletally, I've done that numerous times. Transcortical fixation, sure, can do that. Very technique sensitive, for sure. Or we have other options, of course, a GBR approach. And in Victoria's case, I chose to use the BMP Morphogen, mitogen Morphogen, which is fabulous. Needs a filler, needs some space maintenance. Remember the collagen sponge we talked about is just too soft. It flattens out. It doesn't maintain any space. So we use a filler. I like a mineralized allograft. I've used Mineros now with this in this particular protocol for some 5 years that I've used BMP. It works quite well. We also need some barrier. And here we're using titanium mesh, trying to get away from having to use materials that we have to re-enter and of course take out, especially in the aesthetic zone. But here we did use the mesh, tie mesh. One of the side effects, probably the only one worth even talking about, is edema with this particular technology. And there's no way to avoid it or even take care of it and alleviate it and accelerate the deswelling, if you will. In other words, steroids, NSAIDs, ice really does nothing. This is an osmolality issue, so therefore there's going to be edema. And I tell my patients, hide for 7 to 10 days. Any aesthetic zone work I'm doing with BMP, pretty much have to hide because there will be edema. They'll look worse than they feel. I typically will wait 7 months for re-entries on these cases. And here you can see the before and the after. And yes, it's an N of 1. You're going to say, well, geez, Mike, that's great. But, you know, I've got now over 160 cases and counting. And yes, the predictability of this technology is really sharp. It's in the high 90 percentile like anything else we do. We will grow bone, and we'll grow it dramatically, as you can see here with the pre and post scan. And again, our volumetric renderings, we're able to, once again, place the implant abutment crown complex where it needs to be. We have adequate bone to, in fact, we grew 8 millimeters of bone to be exact, from facial to lingual. And we can place our implant where it needs to be. A 1.5 years out now. This is Victoria's clinical endpoint. And most importantly, we have a system of metrics for the first time as of 8+ years ago to evaluate that labial plate ongoing. Is it really still there? And as you'll see, those of you that come to the corporate breakout this afternoon, I'll show some before and afters of literally no labial plates at all in the aesthetic zone. And we can regenerate those without membranes only mineralized allografts and connective tissue grafts. Those are the type 3, as Dennis showed, defects that we will work with. But here we can follow, is that labial plate intact with BMP? And this is an important point for a lot of us because we want to make sure that what we're talking about now, and I have only 5-year numbers, but so far it's impressive. These plates are holding up well, whether it's in the aesthetic zone or elsewhere. Here we can see, comparing, contrasting, just to shift gears for a bit, edentulous ridge, we'd place some implants, as you're going to see right here, needed implants in the cuspid areas. And as you can see, the bone is narrow. It's a division C-W. But we can also augment with using, in this case, some membranes that are not needing to be removed. So because on re-entry, we're reducing soft tissue volume, we're compromising blood supply. Here we can use these KLS sonic weld meshes that I've played with now for just over 3 years. And there's no question, BMP with this particular mesh, no problem. There was some controversy early on with regard to the pH of this entire environment being so low that it will impact the turnover of the BMP because of the hydrolysis of the membrane. That's not true. At least I've not seen that at all. And I've done a number of these cases now to verify that rather, and know that with confidence this approach works quite well. So just a different way, a little twist of how we can go about using space maintenance barriers, using the sonic weld meshes. And again, we have bone grown predictably. We can place our implant into a D2 quality bone if we wait, again, that 6 to 7 month number. That's important because not all the time will we get to D2 quality bone, waiting less time, that's for sure. So here we're able to get that predictably. And in this quick case, as you can see, we have a horizontal and vertical defect, and we're able to place our implant and use this little shell, as it's called, of the same poly-DL lactide material that will hydrolyze over a period of almost a year total, but by 6 months' time to 7 months, most of it is pretty much hydrolyzed, and again, precludes any need for re-entry and opening up the entire site. And here we're actually using even some small titanium tacks. If you go strictly, purely by what the system is made for, there are the same tacks, if you will, that are made of the same material that breaks down and hydrolyzes without any need for any metal at all. But the key is the mesh itself will hydrolyze and don't have to re-enter. And I've gotten a number of these cases, and others have so many, to validate this protocol. It works quite well. I will finish up with just 3 quick cases in the posterior mandible to compare and contrast the use of different bioactive modifiers, including BMP, including just the mitogens, and even just autogenous bone, and just comparing and contrasting in these cases, I think, the importance of when to use what, where, why. Here we have a young lady who in her early 70s with a bridge that's fractured. And as George Ruelo mentioned, there's no question in the partially edentulous patients, lots of grafting has to be done ongoing. There's no question about that. And fortunately, it's very predictable as long as we follow protocols that have been laid out so well by many, many individuals over the years now. These are predictable protocols. Here, we're going to be extracting these teeth, but most importantly, using, again, cone beam technology, we can assess up front the extent of bone availability. How bad is that deformity? Is it 3-dimensional truly? Is it a width and a height deficiency? Is it only height, or width rather? And if it's width, is it facial? Is it lingual? Et cetera, et cetera. So here we have a width deficiency, and in extracting the distal molar and the bicuspid up front, site preparing, we can use a combination of materials as you're seeing here. Recombinant PDGF 1,000 times more potent than the PDGF in our own blood. And even using PRGF as another mitogen in combination with, as you see here, both an allograft and a xenograft, we can use this as a graft complex. We need a barrier membrane. We need something to basically protect this graft from extravasating. And here I experimented for a number of cases with this high-density porous polyethylene material that is used in the cranial application. There's some great articles in the craniofacial literature that validate this application. However, I will tell you that for oral application, it can be problematic, as you're going to see right here, because it can expose, it can dehiss, and unlike tie mesh, it's very kind and has an exposure rate anywhere from 5% to 55%. doing literature searches and seeing how that particular material works over the years. In our hands now, we're under 10%, doing a number of procedures up front to increase tissue thickness and different flap techniques. We've minimized the exposure, but tie mesh is way more kind to exposure than this material. This material will literally, as you see here, cause loss of tissue volume. And it's not fun to have to flap these and get creative with flap design, and then also secondarily have to soft tissue graft to make up what volume loss we've had. So at any rate, I'm not a big fan of this material anymore, I will tell you that, and I would recommend that you, if you're going to play with this, make really sure you've got very good thick tissue relaxation, and even then you may want to light an extra candle to make sure things are going to work out. At any rate, the volume of this material did maintain itself on re-entry, as you see here. The grafted site did work out well, and we're able to place our implants in a predictable mode, as you see here. And this is a result a year out with, again, having to do a free gingival graft for attached tissue at that site. But our tissue volume was maintained. We were fortunate. But using what? A number of just mitogens. These are, out of the bottle, blood-borne, blood-drawed mitogens that can work well with bone, particulate bone. Here we have Gene, who's a diabetic, 74 years old. And in looking at his case, a little bit different scenario in terms of his medical status, medical health. Not the greatest candidate necessarily for more surgery than would be needed, let's say, in terms of, say, harvesting bone, or is he? Well, again, a sequential digital diagnostic workup, and by the way, by that I mean looking at the entire upper and lower arch at the same time and making sure that we are evaluating everything comprehensively. A number of maxillary molar lesions, in fact, 32%, by Lowe has been shown in the endo literature, 32% of all periapical maxillary molar lesions go undiagnosed with a PA radiograph. So for those of us thinking that that's still the gold standard to evaluate maxillary molar and bicuspid pathology, wrong. 1/3 of those lesions are undiagnosed. You won't miss them on a CT scan. So a comprehensive sequential digital diagnostic workup. Here we're using a tie mesh approach with some particulate graft complex. And in this case, I chose to go with BMP, particulate, meaning allograft here, Mineros. And this combination works extremely well, very predictable. This takes 7 months, however, to re-enter. Okay, the skill sets aren't so demanding in terms of, as opposed to, let's say, we're harvesting some autogenous bone specifically from that same ramus site. So we can, most importantly, our incision design has to be appropriate as it would be for any approach, whether it's GBR, block bone, etc. But most importantly, we can do this in a predictable mode, again, even using PRGF as an adjunctive mitogen bioactive modifier, closing without tension, etc. And again, the value of a post-graft scan, 7 months out, we know we have the bone on re-entry. It's there. We can place our implants in a predictable mode. We evaluate them with our resonance frequency technology, etc. We can take cores. We know we have bone with this approach, and in fact, it's absolutely bone. You can see the nuclei of the cytoplasts in these particular specimens. And again, even on loading, we can now follow this gentleman long term, and again, system of metrics to know that that labial plate is still intact. We've grown bone predictably. And in this last case, just to compare and contrast with the other two, here we have a young lady in her mid-70s, fairly healthy. And as we assess these cases, for me in particular, I'm going to give patients options all the time, as we should all certainly do, in terms of an autogenous harvest. In other words, can we take bone from her ramus buccal shelf? And we're going to assess this because, again, some patients don't have even adequate bone to do that. And she and I together agreed that this would not be such a bad approach for her. We have one wound site. We can take this graft in no time, site prep, and we call it a sliding block graft. We can interposition particulate allograft with our, in this case, PRGF, screw fixate, as you see here, almost with a lag effect, and in essence have a combination of block and allograft with PRGF using collagen membranes that over the years now we've realized, and the literature has shown us, that this will minimize resorption of any of these grafts. And even to this, prior to that point, we didn't have a lot of resorption. to speak of, but now it's well less than 10%. And at a 5-month follow-up, we can evaluate with a post-graft scan exactly how much bone volume do we have. So there's no surprises. On the left, you see time 0, 5 months, there's our bone. We can compare quite nicely, quite dramatically, and this is case to case to case. And not just myself, and certainly not just Craig Mish, but others can do and duplicate the same thing. And that's what science is all about, that these particular grafts work well. And again, predictable. So in summary, when we compare the use of autogenous bone with BMP, the advantages, of course, of the patient's own bone, there's no cost. There's no $900 to $6,000, depending on the defect size. Healing time is minimized. Bone density is great, and there's normal quote-unquote edema versus, yes, increased surgical time, depending on the circumstances, not so bad, limited volume of bone, and donor morbidity. Whereas the advantages of BMP would be just flipping this, of course. A little bit less surgical time for sure, no donor site being involved, and no material limitation. Disadvantages, again, would be cost, healing time, and bone density, as well as edema. So again, we talked about these considerations up front. Most importantly, the clinician skill sets and experience play a huge role with regard to our decision-making, no question. And I, again, appreciate the opportunity to be here with this outstanding team, as I've been affiliated with for a number of years now, and can't thank you enough for an outstanding symposium. Thank you so much.